Thank you so much for having me. I am presenting something that I presented actually for ID Grand Rounds as well, that kind of goes through my journey as a junior investigator who's still learning, and my exploration of this topic as to why I was seeing disparities and inequities in access to PrEP. So here are my disclosures, and I'm going to just go ahead and jump right in. I think most people here understand a little bit of the context as to why we're giving this talk, but I still like to provide it because I think that it gives us a nice background and backdrop as to, number one, why this question is so important. So really, we've been working under this auspice to end the HIV epidemic, and really by 2030. And I am of the belief that we actually have all the tools that we need right now to effectively end the epidemic. So we have highly effective antiretroviral therapy for people who are living with HIV. If they are on therapy, they are virally suppressed, meaning that we can't detect virus in their blood, or it's less than 200 for greater than 6 months. They can't transmit the virus to anybody. We have highly effective prevention modalities, and the one we're talking about today is PrEP, that are almost 100% effective at preventing infection if you are exposed to HIV. And I think the question is, with all of these advancements we've had in the past 40 years and this overarching umbrella of funding now that's been infused into this effort, why are we still seeing such inequities? The other big thing that's happened, I think, that has helped with our ability to conceptualize how we deal with the epidemic is this idea of a status neutral HIV care continuum, and really recognizing the fact that really with HIV testing, number one, we need to have a good understanding of all of those who are potentially at risk for being diagnosed with HIV and how we can engage them into the continuum, into care, and then understand how we can achieve our ultimate goal of viral suppression for those who are diagnosed. So this really is functioning under the auspice that we need widespread HIV testing and linkage to services, full access to PrEP services, and broad support for people living with HIV. And the reason why we're talking about this idea of broad support is because we know that, like I said earlier, there are huge inequities in who has access to effective HIV therapy and prevention. So this article came out in 2017 in the New York Times that talked about a hidden epidemic, and I think really correlated with what a lot of us, especially at 1917 Clinic, we're seeing, and that's that young Black gay men are the population that are primarily being diagnosed with HIV. And the reason why this article, in my opinion, was so powerful is because of this image of this young Black gay man standing out on a road in Mississippi, really by himself, carrying the weight of the epidemic on his shoulders. And I think the question that a lot of us were asking is, what can we do to improve linkage to care for people who are newly diagnosed, who fall within this group? And then how can we improve really diagnosis rates among this group, because we know that they are the group that unfortunately is still seeing increases in HIV rates. Specifically, when we're looking at Alabama, we have a lot of inequities to deal with. Black men right now are 10 times more likely to be diagnosed with HIV compared to their white counterparts. And the group that's most affected and impacted is this young group aged 20 to 29. And this is really reflecting what we're seeing with national trends. This is also the group that's not seeing as much of the benefit as we would hope in regards to decreased HIV rates that we're seeing in some other groups that we've been making efforts and gains in. And then what you can really see is if you're looking at HIV incidence overall, while Jefferson County and Birmingham, where we live right now, have some of the highest incidence rates, there is really a desert of care in our Black Belt. And it's called the Black Belt because of the Black rich soil that is there, that the slaves used to work, and then sharecroppers worked. And unfortunately, there's huge inequities and poverty there that have persisted since that time. So in talking about strategies to stop HIV, really, we have to talk about prevention across the spectrum of sexual health. And today we are only focusing on one aspect of that, and that's PrEP. So the specific type of PrEP that I've been interested in, I've been studying, is a daily oral pill. This pill is, in demonstration projects, 100% effective at preventing infection of HIV if you were to be exposed. And the CDC did this wonderful analysis where they said, based off of our current understanding of epidemiology, of networks, of prevalence, We know that there are 500,000 Americans right now that identify as Black who have an indication for PrEP. We know that there are 300,000 Latino individuals in this country who have an indication for PrEP. And when this analysis was done in 2015, only 1% of prescriptions were being written to Black Americans and only 3% to Latinos. This number has only increased to 12%. So this is a huge inequity. We did a similar analysis in our own 1917 clinic and saw the same discrepancies where the population that is most heavily impacted by the epidemic is not getting access to prevention tools like PrEP. And I think a lot of us are trying to understand the question why. What you can see here is that what's happening in Alabama is not unique. Unfortunately, we're seeing the same discrepancies and inequities across the Southeast, and specifically among men who have sex with men of color. And this is not including and has unfortunately been understudied in what the impact is in our trans individuals, especially trans women and trans masculine individuals, where we are sure the discrepancies are even more heightened. The other thing that we know and that we're working on is that there's this concept of a PrEP to need ratio. So based off of how many people in an area actually need to be on PrEP based off HIV diagnosis rates, how many are receiving PrEP? And I'll add that while we're seeing these huge discrepancies when it comes to PrEP to need ratios among Black gay men in the South specifically, this is also present specifically among trans populations that are persons of color and among cisgender women. So the same groups that experience inequities in other health conditions are being highly impacted and unfortunately ineffectively reached when it comes to prevention like PrEP. We have some insight from prior work as to why we're seeing barriers, and this stems from HIV testing. There's been tons of research studies that have been done that looked at why we didn't see uptake of HIV testing, specifically among Black communities in the South. And we know that lack of insurance coverage has been a huge barrier, so structural barriers exist that make it difficult to access effective preventative health care. There's high cost and overall low benefits when you're looking at your need. Transportation is always an issue, especially in Southern communities where we don't have good public transit. Housing status and when you're unstably housed can be a barrier. And we have really gigantic inequities when it comes to incarceration rates, specifically among Black men and Black Southern communities. And this has led to a lot of issues when it comes to access to preventative care, linkage to HIV care, and linkage to preventative care like PrEP. When these studies have been done, specifically looking at barriers, again, for STI testing, and I want to add the reason why I'm looking at things like HIV testing and STI testing is this all falls in one bucket under sexual health. Plenty of studies have been done, again, showing that there are individual and interpersonal level barriers that prevent access to these preventative tools. So stigma, specifically homophobia, and this is multiple layers and levels of homophobia. So internalized, interpersonal, and experienced homophobia have led to people expressing barriers to accessing STI testing. Stigma specifically with HIV and STIs have been linked to decreased accessing of HIV and STI testing. Poor education around HIV and STIs and transmission and how you acquire these diseases. Discrimination, and I'll say not only past historical racism and systemic and systematic racist systems that have impacted these communities, but current atrocities that are happening right now in history as it's in the making also impact the ability to access these preventative tools. We know that mental health is a huge area that there's a lot of need in, substance use disorders, and overall mistrust in healthcare systems. And then when it talks about barriers specifically for Black gay men and PrEP, we're seeing these same stories come back. And a lot of these have been done with qualitative interviews, which I appreciate because I think that it gets a more granular understanding of what are barriers based off of someone's lived experience. But you'll see again this idea of stigma popping up, and it's been huge. And then something new with PrEP is this idea of a Truvada whore. So if you're on PrEP, that automatically means that you're promiscuous. And because of the messaging that's been done around PrEP, a lot of people have been concerned if you're on PrEP, you're automatically disclosing your sexual orientation if you're a Black man. And these structural barriers still play a role. So PrEP, as we know, and as I've pointed out, is highly effective and could be highly impactful. But when you're looking at what overall and large studies have been barriers to access of PrEP, in the beginnings of when PrEP was first FDA approved, a lot of people pointed to low awareness, and that's just not the case anymore. Multiple studies have been shown that awareness has actually greatly improved among Black gay communities. I think the major issue right now is low knowledge. And awareness and knowledge are two separate things. The other thing that's really been fleshed out and studied is this idea of intersectionality. So how do multiple stigmatizing identities within Black gay men and Black gay communities impact your ability to access preventative tools like PrEP? So under this umbrella, under this context, I really try to form my question as to why we were seeing disparities and inequities within our community in accessing PrEP. And I'm going to show some of my data related to that. So I'm very proud to be a practicing clinician at University Affiliated PrEP Clinic, 1917 clinic. And in 2014, this is when we did our first analysis looking at, are we seeing inequities in who currently is accessing PrEP and who's most likely to be diagnosed with HIV in Jefferson County. And we look specifically at our PrEP clinic because our PrEP clinic is one of the first in our state. And this was of no thanks, personally to me, it was because of the wonderful team that advocated to have a PrEP clinic at that location. And I can say that what I found in this data was mirrored in some of our partner and community-based organizations that also kind of lead the way when it comes to HIV prevention within our state, like AIDS Alabama, Birmingham AIDS Outreach, and Medical Advocacy and Outreach. So in this analysis, this was a retrospective chart analysis, and we found, looking at our Jefferson County case rates, that 62% of new HIV diagnoses were among men who have sex with men, almost 80% among Black individuals overall, 50% among Black men who have sex with men, and only 10% among white men who have sex with men. And then of those 50% among Black men who have sex with men, 19% were in the young category, meaning that they were 25 or younger. And when we compare this to our 1917 clinic population in PrEP care, so who were in 2014 currently providing care for, you can see the huge inequities that were described. So only 18% of our patient population at that time were Black, gay, or bisexual men who have sex with men, whereas 56% were white. And this was one of the first papers that really, I think, identified and disclosed this, like I said, hidden inequity when it came to PrEP provision, that we were not reaching the populations that we needed to. And I think that it spawned for me a passion and understanding how at multiple levels we can identify ways and interventions to improve access to care. So in my K23 award, I set out to say, okay, using a conceptual framework, I used the Anderson's healthcare utilization framework. How can I understand what, from a population standpoint, among Black, gay, bisexual men who have sex with men is needed to improve access to PrEP? I looked at things like PrEP awareness and beliefs and attitudes towards HIV prevention and PrEP. I try to understand environmental barriers to delivery of PrEP. And then at the end of that, develop a targeted intervention to improve access. What I'm going to describe in this first set is really what I looked at in regards to population characteristics and health behavior related to accessing PrEP for Black, gay, and bisexual men. And in this construct for population characteristics, I specifically looked at predisposing characteristics, so identities that Black gay men have not related to the health behavior, enabling resources that could be positive or negative in relation to accessing PrEP, and overall need perceived by my participants. So the first set of interviews that I got funded was through a CFAR pilot that supported this K23 award. And this was among Black, gay, and bisexual men, self-identified between the ages of 16 to 29, trying to understand, for those not diagnosed with HIV, what they thought about PrEP, what their lived experiences were, and what they thought were current barriers to accessing PrEP. For this data, we had 2 interviewers. I worked with AIDS Alabama specifically for this award, and we did a couple of check-ins with their community advisory board that was working on another project at the time to say, what are the optimal characteristics for individuals who conduct these interviews? We started with a Black cisgender woman and a Black cisgender gay man as our interviewers based off of those interviews with the AIDS Alabama organization and their feedback. We had 2 coders. We coded in vivo, and we did thematic coding and had some a priori codes that map back to our conceptual framework. So overall, these are the characteristics for this group of interviewers. And you can see that what was interesting, only 64% were actually self-identifying as gay, men who have sex with men, or same gender loving. We had 1 participant who recognized themselves and identified as heterosexual. At this time, 100% of the people we spoke to were aware of PrEP. This is in 2018. And when we asked who was willing to take PrEP, majority said, oh, we are willing to take PrEP, but the majority were not currently on PrEP. So some of the major themes that we found is that there was a lot of stigma related to PrEP. The question was, if you're doing PrEP, does that mean that you're already engaging in high risk, quote unquote, activities? So I put some really powerful quotes from these interviews in this presentation. This young man said, other people are like, okay, well, if you're doing PrEP, then what else are you doing? There was high levels of medical distrust and questions about what it meant to get this medication that they felt was understudied from a medical system that had been proven to be untrustworthy. Almost no one actually felt that they needed to be on PrEP. So there was an overall low perceived need. And this has been well described in the literature since this point. So this individual discussed PrEP as a drastic step needed to take to prevent something that they didn't feel they were at risk of getting. They talked about the Black community. And I thought this was probably the theme that really spoke and hit on the nail of intersectional stigma. So they talked about the idea that within the Black community, there's an overall silence around sexual health, a lot of it related to religion and religiosity. And they said that that silence around being able to be sexually healthy hurt them the most. And this individual specifically is talking about not only silence within the Black community, but within his family. They talked about a lot of stigma related to being Black, gay, and living in the South. And this quote actually just really broke my heart. I don't feel like there's ever a time when they've engaged in a sexual encounter where they've had true peace of mind. Every time they reported engaging in sex, they felt shame. And then there was this sub-theme of perceived masculinity and how being Black and gay and living in the South was an affront to what conceptualized masculinity was within that community. The other thing I pointed out in this paper was that while almost all of the participants said, we are willing to take PrEP, when you actually looked at codes, and I presented this in the paper, about whether they would be willing to start, their intent to be on PrEP, willingness and intent did not correlate. And most people said, this is a drastic step. This isn't for me right now. I'm not currently at risk. There was an underlying theme that I talked about in another paper separate from this, where I did some fine coding to talk about the journey to self-acceptance of their sexual identity. Because I noticed when I was going through the coding process that it really was a journey, and that for those individuals who reported that they had accepted their sexual identity, they actually usually were more likely to say that they were willing to use PrEP and had intent to start PrEP. And so when I looked at what that journey entailed, there was, again, this underlying theme of homophobia, internalized, perceived, and experienced. And some of the experienced homophobia was actually quite severe. So people being hospitalized because they were beaten up while they were in high school by multiple individuals, people trying to murder them within their family, that just really horrifying stories about lack of being accepted within their social circles. There was also this idea of the social network and what support looked like. And I thought this was really interesting because they talked about complex bonds. They talked about bonds with other Black gay men once they became comfortable with their sexual identity. But they also talked about a lot of times that first person they came out to, and a lot of times that being a Black gay woman or a Black family member that was a woman who really sometimes expressed overall acceptance of who they were, that helped them gain acceptance. And when they didn't get met with that, it seemed to cause some pretty severe down trickles later on in their lives and their ability to gain that acceptance themselves. And they talked about, again, these cultural norms within Black communities needing to change. A lot around religion and dogma around being gay, the idea of what it means to be bisexual within the gay community, and heteronormative ideals within Black communities. So I thought to myself, okay, perceived need came out as a big theme in this set of interviews. And so I'm going to talk to people who are newly diagnosed with HIV, who obviously, based off their diagnosis, they were unfortunately at risk for being diagnosed with HIV, and ask, PrEP was available to you at this time. What were the barriers to you accessing PrEP? I again used the same conceptual framework I used for that first set of interviews, and this was with 23 individuals aged between 16 and 29. These are the overall demographics for these individuals. And I asked them, do you think that you would have been willing to take PrEP before you were diagnosed? And only 36% said yes. So they said that PrEP had a lot of negative associations. So a lot of HIV stigma related to PrEP, because they said it's basically an HIV pill. So they didn't want to be on something that was related to HIV. Again, homonegativity came out. And this idea of being on the down low. So if you're on PrEP, you're unintentionally disclosing the fact that you are gay. There was low knowledge, they said, about PrEP. They felt like they didn't know who PrEP was really for. A lot of times they said in our community, we are too proud or we're not knowledgeable enough on something, and we feel as though if this person isn't doing it, then why do I have to do it? And they said that there was really no accessibility to PrEP. So do you need insurance? What does it cost? What are the side effects? And that, again, was that difference between being aware and actually being knowledgeable about what it took to access PrEP. And then low perceived risk. And this, I think, is a fail of us as providers and as public health officials in talking about this, again, concept of risk. So most of them said, when I was diagnosed with HIV, I was with one trusted sexual partner. How does that put me at risk? And then when they're young, they feel like they're invincible. I mean, these are individuals who were between the ages of 16 to 29 who were newly diagnosed with HIV. So most of them at that time did not think, I need to think that far ahead about prevention of HIV when I'm this young. And I asked them specifically, how do we increase knowledge around and interest around PrEP among young Black gay men? And they said, you need to reduce the stigma and make it acceptable for Black gay men that are not comfortable with their sexual identity. And they specifically spoke to media portrayals right now, and that right now, if you're on PrEP, it automatically means that you're gay, and that it needs to be more about the community and sexual health. And I'll say, as a side note, this was not something that was popular. I remember I was at a conference presenting this data, and I had a really great advocate who was a Black gay man who was from Chicago come up to me and say, this is counter to what we need as a part of the Black gay community. This is counter to what we need to be part of the movement, saying that Black gay men can't be on PrEP commercials. So this was very controversial at the time. I think that there's more movement behind this idea, but again, I think still more work needs to be done to understand what we need to do around messaging. So I coupled this with a survey, and I took from those in-depth interviews some of the themes to include them as validated scales within the survey I did with 300 young Black gay men. And this data has yet to be published. I still need to publish it. So these surveys were done really with people who were HIV negative, self-report. They report they had sex with a man in the past 6 months. They were Black, they were English speaking, and they were aged between 16, and this should be 29, not 24. And I went back to my conceptual framework again, based off of what I found in the in-depth interviews. And these were the instruments that we included. It was pretty long. I don't know if I would do this survey again because it was so long, but we had questions around religiosity. We had questions around social support on multiple levels. We had questions around sexual acceptance and their sexual identity. It was really a all-encompassing survey. And this is kind of what we found, which I thought was interesting. Again, perceived risk and adjusted was one of the only variables that predicted actual use of PrEP, which was my primary outcome, meaning you had been prescribed, and PrEP knowledge. But when I looked at my unadjusted model, you'll see a couple of things pop out. So people who were unstably housed, stably housed were more likely to be on PrEP. Higher levels of education, more likely to be on PrEP. If you had transportation, you're more likely to be on PrEP. People who were depressed were less likely. And what I thought was interesting is this concept around religiosity. So if you reported that you were intrinsically religious, meaning that you had spirituality, but not necessarily went or attended church, you are more likely to be on PrEP. And of course, social support across the board, you are more likely to be on PrEP. And then I looked at things like perceived sexual stigma. and total sexual stigma. And that actually predicted PrEP use, whereas healthcare stigma did not, provider trust did. So I think what I need to go back and do for this is actually do some mediation analysis and see how these variables relate to one another to understand if there's a pathway by which some of these variables that I found in the unadjusted model relate to what came out positively in the adjusted model. So I went back to the drawing board based off what I found, and I made an updated conceptual framework where I said, okay, I think from an information standpoint, we need to focus on things like PrEP knowledge, information about how you actually get PrEP, so true PrEP knowledge, and what it means to be at risk, which really has nothing to do with, unfortunately, your current sexual behaviors, but it has to do with the prevalence within your community and how dense that network is. We need to focus on motivators. And I noticed that there was this huge thing when it came to social support, specifically from family, significant others, and friends, and intrinsic religiosity, and focus on behavioral skills we need to access PrEP. So are there coping strategies that we can leverage that will improve access to PrEP around provider trust, stigma related to sexual identity, and barriers to transportation, housing. Overall, I thought the way to overcome these issues is to leverage already existing networks and improve the bonds between those networks through something called social capital. So social capital can be defined as the sum of an individual's resource-containing, reciprocal, and trustworthy social network connections. And basically, it looks at different types of bonds, either bonding capital, where it's through members of a group that are similar to you, or bridging capital, when you have these cross-identity connections, and how these connections can be leveraged and utilized to get support towards a health behavior. So either informational support, instrumental support, emotional support, really tangible goods that you can use and allocate to access this health behavior. And the best example I can give of social capital is the civil rights movement. So when we did the bus boycott in Birmingham, Alabama, the ability to support your neighbor, if someone didn't get to go to work because they were boycotting the bus, to make sure that those individuals got fed, to have tangible goods that could be shared in order to achieve a shared goal. And so I think, and this is what I'm working on right now, one of my R34s, by increasing the social capital within Black gay networks and looking at it from not only networks that are the same, but these bridging networks with Black women as well, how can we access and improve PrEP utilization among this group? So I'm currently funded for this. Right now, I'm saying that I'm going to work with young Black gay networks between the ages of 16 and 29. It's going to be 4 to 5 individuals, and they're going to enter into the virtual world together. They're going to do an app called HMP app, which has been studied and used by University of North Carolina. And in this app, they're going to have sessions where they talk about the information, motivation, and behavioral skills needed to access PrEP. It's going to be over a 4-week period of time. These are the actual operationalized concepts and how I said it would relate to PrEP. So focusing specifically on information, which I color-coded as blue. So HIV prevention information and sexual health information related to PrEP within these small group sessions. Focus 1 week on intersectional stigma, talking about what it means to be a Black gay man living in the South and what they use within their own networks and their own personal skills to cope with that. And then how specifically you can engage into PrEP care in the last week. This is the study design for this. So ultimately, I'm saying that we're going to enroll based off of a individual and then work from that individual to their network to ultimately enroll 4 to 5 Black gay men within a network and have 1 Black female lead that's connected to them. And that these individuals, this network will go on this journey together over this 4-week period of time. Half of the individuals will get the intervention that's going to hopefully improve social capital and access to PrEP, and half will get standard of care, which is what is currently in the HMP app. So I'm going to circle back because ultimately this is one aspect of my research, and I decided to branch and really, like I said, focus on the whole. So how can we improve sexual health within Black communities? So number one, going back to this New York Times article, I thought about this man standing on this road, and I thought, you know, my view of him is wrong because I've been viewing him as this sad martyr who is, you know, unfortunately isolated in this journey through the HIV epidemic. And really, this individual is what we should all be striving for, because he's strong enough to stand on that road by himself. And I think we need to have others be willing to join him. And so understanding that and changing my viewpoint around that, I wanted to understand how we could improve sexual health among Black women. One individual, Lori Dill from MAO, also said to me, like, Letitia, we can't act like these issues happen in a silo. We can't only talk about Black gay men. We have to talk about inequities and disparities within Black women as well. So right now, we know that women account for 1 in 5 new HIV diagnoses, and 70% of women infected are actually Black. So a Black woman right now has a 1 in 48 lifetime risk of being infected with HIV. So again, when we're talking about how do we end the epidemic, we also have to address inequities that are occurring among racial groups across the board, and that includes cisgender women. Talking about need, you can see that while we have seen gains, and this is primarily among white gay men self-identified, with PrEP access, we have not seen those gains among women. And whereas we've done a great job when it comes to PrEP awareness among the gay community specifically, due to our messaging and marketing campaigns, the same cannot be said for cisgender women. So only 7% of women actually are aware about PrEP in this one survey that was done in 2018. So shifting to understanding really what it means to be a Black woman, especially in rural areas in the South, and how that impacts your ability to access things like PrEP. I went back to the drawing board and I did a set of focus groups for this study. So this was funded by Robert Wood Johnson Foundation. And I had 2 Black women doing these interviews. And again, I did the same type of thematic coding and really phenomenological coding, trying to understand the lived experiences of Black women and how that impact their ability to access PrEP. What is amazing is where we were able to do these interviews. So we went to 2 urban counties, Jefferson County, which many of you will recognize this, and Montgomery County. But we also went to the Black Belt. When I say we, I mean my wonderful research assistants. I went only to a couple of the interviews, but they were amazing. So they went to Lowndes County. Lowndes County has been called the place that God forgot in the roots. And this is a lot of times due to the fact that they have faulty septic tanks and many residents have waste backing up into their yards. We went to Wilcox County, which is has one of the 10th highest poverty rates in our country right now, and a median household income of $24,000. This is Wilcox. We went to Selma, Alabama. And this is a picture from a story where they showed a woman talking about how this is still a city of slaves, where she gets paid $10 a day to remove bricks from this area. And we went to Macon, Tuskegee, Alabama, which I think unfortunately speaks for itself. So I was so proud to be able to say that we went to the Black Belt to do these interviews and to understand what were barriers for PrEP access. So we actually oversampled from the rural area because I didn't think we were going to do that well, but we got 44 women from the rural area and then 22 from the urban area. And this is some of the demographics for these populations that we were able to sample from. And I think it's actually pretty even across the board. Among the rural group, you will see that there's higher levels of only reporting having a high school education, and that the median household income was lower among the rural population. But overall, most people did report having private insurance with higher levels of Medicaid or being uninsured in the rural group. So we looked at themes across these groups that were the same, that we thought were more prominent within the urban population and more prominent in the rural. We thought that lack of HIV knowledge was prominent throughout, low perceived need for PrEP, lack of education on PrEP, especially for Black women. And I will say in this theme, there was a lot of homonegativity that was expressed among the women, and multiple structural barriers to accessing PrEP. Among the urban women, there was way more HIV stigma, and they thought that that was a major barrier to accessing PrEP. And when we talked to the rural women, it was really about distrust of the medical system and this fear that if I go and I access PrEP, we all know each other. So it's going to be unintentionally disclosed that I'm accessing PrEP, and people are going to think I'm a promiscuous person because of that. They also talked about in their greater needs, healthcare was not prioritized. They were more worried about things like paying your power bill, electricity, and things like food insecurity. The other thing that we asked, which I thought was great, is we tried to use these groups to understand what attributes were important when it came to PrEP service delivery. And we did this to inform a discrete choice experiment that we did, looking at what PrEP service delivery preferences really popped out as prominent among these women. So they talked about how provider type is very important. They really wanted to have a personal relationship with the person that they saw. They thought where you access PrEP was important, where you actually picked up the medication was important, because a lot of people were not trusting pharmacies to go and pick up PrEP because someone might recognize them, and frequency of visits was discussed a lot as well. So for many of you, or for some of you, at least for me, I did not know what discrete choice experiments were when I first started this journey. And I quickly found out that it is something that has been used in behavioral economics for a very long time. Ultimately, what you do is you have multiple attributes that can have different levels. So if I say I care about healthcare facility, the medical professional, where I receive my medication, the PrEP medication form, and frequency of visits, these are all attributes in my model. And then I can have different levels within them. So I could say for healthcare facility, I'm going to look at telehealth versus SU clinic versus family planning clinic. For medical professional, I'm going to look at a general or family practitioner, or pharmacist, or OB-GYN. And what this survey technology does is that it actually learns from your answers. So in this actual package, I say, okay, of all of these, this service delivery package is the most desirable to me. Based off how I answer, it will say, okay, you said that telehealth is important to you. Is that what's really driving your decision-making process? And based off that, you can actually weight what attribute is the most important among your individuals in your survey. So here's what actually popped out for us. You can see that number one, oops, I went backwards. We saw that there were, for our I don't know versus no versus yes, and willingness and intent to use PrEP, there was a bit of a difference when it came to age. So people who were younger were more likely to say that they were willing to use PrEP. There was differences in intrinsic religiosity, with higher rates among people who said that they weren't sure or they were unwilling to use PrEP. We again saw things like social support pop out, and really higher social support seen among people who said no, which was interesting, specifically among significant others. We also looked at experiences of discrimination, and we saw higher levels of experience of discrimination on people who said that they were not willing. We saw the lowest HIV knowledge among people who said that they were not willing to use PrEP. And then we looked at things like if you had a PrEP indication or not. And you can see that the people who had the highest PrEP indication actually were least willing to use PrEP. Here's my discrete choice experiment, and this is looking at the actual hierarchical Bayesian analysis for PrEP service delivery preferences. And I'm sorry if some people have already seen this data, but I think it's probably one of the coolest analytics that I've done, where if you look at healthcare facility, the majority, and this is looking at people who said no versus unsure versus yes, whether they be willing to use PrEP, so that they want to get it from a doctor's office. There was no differences among those groups. Looking at type of medical professional, you'll see that everyone wanted to go to their gynecologist. And we had a few individuals in the no and unsure box who said, I'll go to my general practitioner, but OB-GYN came out true and strong. Most individuals want to go to their doctor's office to receive their medication, which actually correlated well with what we found in our in-depth interviews and focus groups. People were either interested in a pill or a long-acting shot, and people did not want to be seen frequently to come in for PrEP care. We looked at latent class groups to see if some individuals and their answers were kind of hanging together. And what I thought was interesting with this is that we did actually see differences. We saw that people who really were interested in things like long acting wanted, let me see if it pops up. There it goes. People interested in long acting were more likely to be in our groups that had higher levels of women who were rural and higher degrees of stigma. So I thought that was interesting because I think it also correlated, and again, this is all conjecture, with their ability and desire to not have the fact that they're accessing PrEP services be disclosed. So group 4 had the highest percentage of rural participants of any of our groups, and they were the ones that preferred online or telehealth PrEP the most. So this bond 1 R34 that I'm currently working on called PrEP for Her, it's integrating PrEP into GYN care. This is an implementation study. So I'm looking at, number one, how can we show that by going into a GYN facility, that that's effective and acceptable and feasible for accessing PrEP, and then what strategies are needed to actually successfully do this. Because right now we're getting baseline data by interviewing and doing surveys with gynecologists, but sometimes for many gynecologists, taking a sexual history and doing the STI and HIV testing needed to deliver PrEP is not a part of routine care. So I have changed my concept of what it means to have a status neutral HIV continuum. And I think overall, it means that you have comprehensive sexual health care, including STI screening, management, and preventative services that addresses and recognizes the complexities of disparate access to PrEP among communities as a whole, like Black communities, Latinx communities, and trying to understand how we can leverage some of the already existing strengths within those communities to improve access. So I think this has come full circle. There is something I'm working on right now, and I'm sharing it with you all. I don't know if it's ever going to get funded or see the light of day, but I want to actually do a comprehensive sexual health intervention within school systems, and specifically a school system that's located in Florida. This is a school system that has been created for girls who have fallen out of traditional school systems across the state of Florida. And these girls have high rates of trauma because unfortunately they have high rates and social determinants of health that have left them kind of left behind by traditional school systems. So they report high rates of physical abuse, sexual abuse, and most of them are actually living in foster care or have touched the juvenile justice system in one shape or form in their lives. So I'm saying this is going to be a multi-level intervention. I'm going to improve knowledge among the girls in regards to their sexual health, what it means to be sexually healthy, and do it using a gender transformative approach, meaning that I'm looking at harmful gender norms that have been taught, and I'm trying to reverse those gender norms. I'm going to improve their relationships with their teachers and counselors by training the teachers and counselors on what it means to be gender responsive and gender transformative, so tackling harmful gender norms. And then I'm going to train them on what it means to be sexually healthy in regards to STI and HIV prevention. And then in the school itself, we're going to offer STI and HIV testing and then PrEP navigation to health departments that are offering PrEP. For this, I'm saying that I'm going to do a cluster randomized trial with 20 schools. 10 are not going to get this intervention. 10 will get their the actual, I'm calling it Sisterhood 2.0 intervention. And then I'm going to look at things like overall incidence change in STIs. I'm going to look at uptake of STI testing. I'm going to assess knowledge and beliefs among the teachers and the students before and after they receive this 8-week curriculum. And I'm going to do it over a year's worth of time, testing it over time to see if there's changes. So again, this is something that I have submitted. We'll see how it goes. And it's kind of pie in the sky. But I think that it addresses, like we've been talking about throughout, this idea that we can't look at this at an individual level only. We really have to tackle this from a community standpoint and improve the areas and the places and the circumstances in which Black gay men, Black cisgender women, Black trans individuals live in, to truly tackle sexual health and improve HIV prevention and end the epidemic. So I want to say a really special thanks really to everybody. This work was supported by tons of community-based organizations, like I said, that are boots on the ground, that are doing this work in areas where no one really has tried or been successful in accessing and improving sexual health. I've had several mentors on these grants. I want to say a special thank you to Michael Bugavero and Janet Turan, my research assistants, the Research and Informatics Service Center, and then all of the collaborators I've had on these grants as well. So thank you. And then most importantly to the participants.